One key challenge in healthcare improvement is why evidence-based policies often don't work as intended. Interpretive policy analysis helps us understand why. It reveals how the same policy means different things to different people. Understanding these meanings, the values, the interests, and the communities behind them, makes us better advocates and helps us to design improvements that have a better chance of working. Traditional approaches focus on rational and objective problem solving, finding the best solution based on evidence, costs, and expected outcomes. What they miss is how politics, power, values, and competing interpretations shape what gets defined as the problem and what counts as the solution. Interpretive approaches start with the assumption that a particular policy or programme will mean different things to different people. The interpretive analyst seeks to make sense of the multiple groups and communities in a policy field, exploring how a policy is understood and enacted. This can reveal underlying problems, unintended consequences, and how they might be addressed. One tool interpretive policy analysts use is storylines, narratives that policy actors use to further their interests or unite disparate groups. A number of storylines, potentially contradictory, can hold within the same policy field. Interpretive policy analyst Martin Heyer identified competing storylines hampering the reconstruction of Ground Zero after 9/11. 4 disparate groups saw the site as having different purposes, and a rebuild would need to satisfy these: recovering financial investments, ensuring the site remained a memorial, providing an opportunity for rejuvenation, and demonstrating a symbol of resilience and that we won't be beaten by terror. In my This Fellowship, I'm using interpretive policy analysis to explore the context in which structured medication reviews to address overprescribing and problematic polypharmacy have arisen. My analysis revealed a storyline about waste. Let me take you through the research and how I got there. Polypharmacy is a term used when someone is prescribed 5 or more medicines. Polypharmacy is on the rise globally. 20 years ago in England, 12% of adults over 65 took 5 or more medicines. Today, it's nearly half of adults over 65. In older adults, polypharmacy causes real harm: medicine errors, adverse drug events, falls, and hospital admissions. Evidence has shown that the risk of harm increases with each additional medicine item consumed. Despite this, 10% of GP prescriptions are overprescribed. That is, they are not needed or wanted. England's response to this problem hinges on the potential of the structured medication review. These are a NICE-approved intervention. A patient is invited to a 30-minute consultation delivered in general practice settings, usually by a clinical pharmacist. The medication review is proposed as an opportunity to optimise the patient's medicines, reducing, stopping, or even starting medicines according to the patient's needs and wants. My research dataset includes publicly available documents, including documents from the Department of Health, NICE, professional organisations, and patient advocacy groups. In-depth interviews with key policy stakeholders drawn from the Department of Health, professional bodies, academia, and integrated care boards. And as a final step, video reflexive ethnography enables access to the on-the-ground practice of structured medication reviews. Video reflexive ethnography entails observing and recording practice and then inviting patients and practitioners to reflect on this. Policy documents were at pains to emphasise the benefits and values of medicines, yet nearly all made a distinction between polypharmacy that is appropriate and polypharmacy that is inappropriate or problematic, the latter causing waste and harm. At the same time, English policy documents and stakeholders I interviewed were reluctant to use the term deprescribing, the planned and supervised process of dose reduction or stopping of medication that is not needed. This was in sharp contrast to nations such as Scotland and Canada, where significant inroads to reduce overprescribing have been made, and where deprescribing is part of the common professional language. In England, policy documents warned about wasteful prescribing. Half of long-term medicines aren't taken as intended. But polypharmacy as a waste story means different things: financial waste to the NHS, due to the unnecessary use of prescribed medicines, waste of resources as overprescribing presents safety risks to patients, including hospitalisation, and wasted time and quality of life for patients prescribed medicines they don't want or no longer need. One clinician emphasised the need for preventing this waste using an overflowing bath metaphor. He says, "We've got to pull the plug on problematic polypharmacy. What we all need to learn to do is turn off the taps." This raises questions about who is responsible for the rising tide prescribing. Turning the taps off on polypharmacy may go beyond what is possible in a medication review. It points to a need for a culture change in the health system as well as in broader society. We can also think of waste in terms of lost opportunities to discuss medicines. Patients are told that they need to have honest conversations with their GP and pharmacist and not be afraid to reveal when they might not be taking their medication. The Chief Medical Officer goes further and says that those in later old age have to have realistic discussions with their doctors about whether more treatment will improve quality of remaining life. There's also an emerging environmental storyline about medicines waste. Medicines contribute 25% of the NHS's carbon footprint. Policy documents flag the issue and stakeholders recognised its value, but delivering this in practice remains a challenge, as this GP told me. It's yet to filter down to practice. There's not enough information to support our clinicians to carry out this concept of environmentally conscious and sustainable prescribing. This storyline can therefore be seen as a policy ambition, but it remains to be seen how during the medication review, GPs, pharmacists and patients might start to address the problem of waste from prescription medicines. The complexity of overprescribing cannot be solved by a single intervention such as the structured medication review. Interpretive policy analysis allows us to see this. Structured medication reviews will remain important for individual patient care, but they alone are not likely to address the root causes of polypharmacy. To address problematic polypharmacy and overprescribing, policy actions may need to consider how we address our medicines prescribing culture more broadly. For example, what are our expectations of treating illness and disease, particularly in later life, and how will this impact quality of life? We may need to adopt new approaches to engage and enable patients to speak openly and honestly to their healthcare professional about what they want from their medicines. And this is work we're developing at Queen Mary, University of London, with our Let's Talk Differently About Medicines storytelling workshops for adults. It is also why it's essential that deprescribing networks are established in England, which will enable health professionals to find a community of practice where they can gain the confidence and courage to raise the option of safely reducing or stopping medicines. Interpretive policy analysis helps us understand why policies fail, because different groups interpret them differently. And this matters for healthcare improvement. It helps us make sense of what is really going on. Interpretive policy analysis provides the systematic tools to explore how a policy is understood, interpreted, and enacted. Through documentary analysis, stakeholder interviews, and ethnographic observation, the analyst can obtain a wide range of perspectives on the policy in question, reveal underlying problems, and identify unintended consequences and consider how they might be addressed. And with this knowledge, we can design more effective interventions, anticipate where there might be resistance, identify groups who ally with our intended policy actions, and identify those groups who might need to be brought into the fold and united. Thank you for listening, and please get in touch if you would like to discuss my research further.